Good afternoon, everyone. My name is Lynette Corona. I am the Healthcare Program Specialist at CDPH's HAI program. I will be your host for today's webinar. Please ensure that you are connected through WebEx and able to view the slides and not only listening to the audio, as you will need to view the slides to participate in this training. The presentation slides and recording will be shared with all participants and posted to our website. On behalf of the California Department of Public Health, CDPH, Healthcare Associated Infections, HAI program, I'd like to introduce today's webinar entitled Prevention of Candida auris and Other Novel Multidrug-Resistant Organisms in Healthcare Facilities. The webinar will be presented by Drs. Aaron Epson and Alfonso Hernandez. Dr. Epson is the Chief and Medical Director of the HAI program at the California Department of Public Health. Dr. Hernandez is an Epidemic Intelligence Service Officer with the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention. He is also Lieutenant Commander in the U.S. Public Health Service. We will have a question and answer period. Due to the size of today's webinar, we will not be opening the audio lines during the Q&A to avoid background noise and any potential audio feedback. Instead, we ask that you use the WebEx Q&A panel for questions. To access the Q&A icon, use your mouse to click on your monitor screen, and on the bottom center of your screen, you will see several icons appear. Click on the circle with 3 dots. There you will see the Q&A option. The Q&A panel will open on the right side of your screen. Thank you, and I will now turn the presentation over to Dr. Epson.
Thank you, Lynette, and can you hear me all right?
Yes.
Great. So, hello everyone, welcome and thank you for joining us today. So you might be wondering, why are we talking about Candida auris and other multidrug-resistant organisms, or MDRO, during this surging COVID pandemic? Well, this figure here shows the number of reported cases of Candida auris, shown as blue bars, by month, starting way back in January of 2017. And you can see that we had a regional outbreak in Orange County during the first half of 2019, which was eventually controlled. But then now, since the first quarter of 2020, we've seen a dramatic resurgence in cases. And this recent increase is predominantly in Southern California, in Orange, as well as Los Angeles County, in primarily long-term acute care hospitals and ventilator-equipped skilled nursing facilities. And this resurgence of Candida auris cases also closely mirrors surges in COVID-19 cases, and those are shown by the orange line. Although the number of Candida auris cases appeared to decrease in October and November as a result of the number of interventions that you'll hear more about today, we are concerned that now that COVID cases are surging again, we need to be vigilant for the potential that we could lose ground on our progress with Candida auris containment and other MDROs. And so what are our key messages today? We understand that healthcare personnel and facilities are doing their best given these very, very challenging circumstances with the ongoing COVID pandemic and related disruptions, safety concerns, supply shortages, all of which are leading to infection control lapses. However, Candida auris and other novel multidrug-resistant organisms are still a major concern. But the good news is that strengthening basic infection control practices will lead to reduction in transmission of both Candida auris and MDRO, as well as SARS-CoV-2, the virus that causes COVID-19. And these are a benefit to both patients and healthcare personnel. And we have public health resources available to you to help support MDRO testing and containment, even during the COVID-19 pandemic. And so today, I'm pleased to introduce speakers from the Centers for Disease Control, as well as from Los Angeles County Department of Public Health, who are going to present on the coordinated response to Candida auris resurgence in Los Angeles County. Dr. Alfonso Hernandez will be presenting on behalf of the CDC. We also have Dr. Zach Rubin, as well as Sandy Bauerla and their team from the LA County Department of Public Health, who, although not presenting, have been instrumental in this response. And all of us will be available to answer any questions you might have at the end of the presentation. So please enter those into the Q&A portion. And with that, Lynette, could you please pass control of the presentation to Dr. Hernandez? Thank you.
All right, can everyone hear me okay?
Yes.
Yes.
Okay, and can everyone see the slides as well?
Not as of yet.
Let's see. Oh, what about now?
They're all right. They're all ready to go.
Perfect.
Good to go? Okay. All right, well, good afternoon, everyone. It's really a privilege for me to be talking to you today, and thank you for inviting us. So today I'll be talking about Candida auris and other novel multi-drug-resistant organisms with a specific focus on long-term care facilities. And before we dive into the presentation, I really want to thank all of you for your hard work caring for some of the most vulnerable people in our society. Like Erin said, these have been very difficult times for everyone, and you've all demonstrated incredible courage and compassion. So thank you so much for your continued efforts. So the objectives of this webinar are really to describe novel multi-drug-resistant organisms with a focus on Candida auris in long-term care facilities. And I'll be referring to multi-drug-resistant organisms as MDROs throughout the rest of the presentation. I'll talk about the Los Angeles County Department of Public Health and CDC investigation performed in long-term care facilities. And I'll end with some highlights of how you can prevent the spread of Candida auris and other novel MDROs. And I'll also be addressing some of the misconceptions regarding infection prevention and control practices that we encountered during our investigation throughout this presentation as well. So what are novel MDROs? So novel MDROs are bacteria and fungi that are resistant to all or most antibiotics, making them very difficult to treat, and that are either uncommon in a geographic area, such as Candida auris, or they have special genes that allow them to spread resistance to other organisms. And these special genes are most important in bacteria. So these novel multi-drug resistant bacteria pose a special threat because these genes that they have, which are called carbapenemases, make them resistant to carbapenems, which are a type of antibiotic and are the broadest spectrum, and that we often have to use as a last resource in really difficult to treat infections. And carbapenemases can be shared by different strains of bacteria, which allows them to spread rapidly. So you can think of these carbapenemases as code or software that can be transmitted from an antibiotic resistant to an antibiotic sensitive bacteria, as shown in the picture on the upper right portion of the slide. And I just want to introduce some of the common terms that are used in healthcare when referring to novel MDROs, because it can be very confusing. So it's not really important for you to know about the specific organisms, but rather know how they're referred to, so that you know if someone says something like CPO or carbapenemase producing organism or CRE, you know that they are referring to a novel MDRO. And similarly for carbapenemase enzymes such as KPC and NDM. So if you are looking for more information regarding these organisms, I have placed 2 links to CDC websites at the bottom of this slide. And just as an example of how quickly these carbapenem-resistant organisms can spread, since the first identification of carbapenem-resistant Enterobacterales, also known as CRE, in 2 U.S. states in 2001, CRE has spread to all 50 states, the District of Columbia, and Puerto Rico in only 16 years. So it's important to also know that novel MDROs are not the same as endemic MDROs, like methicillin-resistant Staph aureus or MRSA, or vancomycin-resistant enterococci, or VRE, which you are likely very familiar with. Novel MDROs require more aggressive intervention precisely because we don't want them to become as common as MRSA or VRE. So while we will not be addressing endemic MDROs in this talk, I think it's important to know that all MDROs spread in similar ways and can be prevented using the same infection prevention and control principles. So that if you use strategies to prevent Candida auris, you're also preventing the spread of other MDROs. So now that I've introduced novel MDROs, I will talk about how they're transmitted, how they're spread, and what are approaches to stopping them. So we've all been very concerned about respiratory precautions in the last year to prevent the transmission of SARS-CoV-2, which is the virus that causes COVID-19. But we need to remember that novel MDROs spread primarily through contact. So a healthcare worker caring for a resident or patient with a novel MDRO can spread it through contaminated hands or medical equipment such as stethoscopes to other residents, other healthcare workers, and environmental surfaces, including mobile medical equipment, that can then transmit this to other residents. And we can interrupt the transmission of novel MDROs by implementing core infection prevention practices. So these are hand hygiene, cleaning and disinfection, transmission-based precautions and correct personal protective equipment use, and the use of dedicated medical equipment. And one of the big challenges for control of novel MDROs is that we're aware of the tip of the iceberg, which are patients with active infections. But we could be missing the larger portion, which is colonized patients. And colonization, or saying a person is colonized, means that a person is carrying an organism in some part of their body, but does not have symptoms of an active infection from that organism. And colonized patients are still able to spread the germs to others and could develop infections themselves. Now, screening for novel MDROs helps identify these colonized patients and prevent transmission, and this can be in the form of facility-wide point prevalence surveys as part of investigations, or by screening newly admitted or readmitted patients for novel MDROs. In addition to under-detection of colonization, gaps in interfacility communication can also contribute to novel MDRO spread. So the picture shows the spread of residents or patients with CRE, which are represented by purple triangles, from acute care hospitals in yellow to long-term acute care hospitals in red and nursing homes in green. As you can see, spread is amplified in long-term acute care hospitals and nursing homes, which are shown in red circles. And this is because of long lengths of stay, provision of care to high acuity patients, and also limited resources for infection control infrastructure relative to acute care hospitals. So this is why communication between facilities of admitted, discharged, or transferred residents that are colonized with or have active infections with novel MDROs is really important. Communication should also include local, state, and territorial health departments so that these can track and alert healthcare facilities of outbreaks, share information, and implement shared infection control actions to stop the spread of novel MDROs. So this figure summarizes some of the concepts I touched upon in previous slides. Our approach to containing the spread of novel MDROs is rapid identification, performing infection control assessments, evaluating the core infection prevention practices of hand hygiene, cleaning and disinfection, implementation of transmission-based precautions, and use of personal protective equipment, among others. We perform colonization screening and implement coordinated response between facilities and public health authorities. And containment requires ongoing assessments and may need multiple rounds of infection control assessment and colonization screening before novel MDROs are contained. And COVID-19 presents new prevention challenges for novel MDROs due to the strain it has placed on our healthcare system. Shortages of staff, personal protective equipment, alcohol-based hand sanitizer, and cleaners or disinfectants make it difficult to have optimal core IPC practices. In addition, the increased volume of residents or patients, the burden placed on infection prevention programs to focus on COVID-19, and concerns for healthcare personnel safety all play an important role. So during the COVID-19 pandemic, we have seen a resurgence of cases and outbreaks of novel MDROs. So the goal of this webinar is really to remind you that our tried and true infection prevention and control practices work for novel MDROs. We just need to adapt the resources we have at this time to keep our patients and ourselves as safe as possible. So with that introduction, I will move on to the specifics on Candida auris. So Candida species are yeast that are the cause of many common infections, such as thrush in the mouth. They can also cause serious infections, such as bloodstream infections and infections of the heart or brain. Candida auris is an emerging multi-drug resistant type of Candida that can cause these severe infections. And Candida auris was first reported in Asia in 2009 and was first detected in the United States in 2015. And since then, clinical cases have continued to increase, as shown in this graph and as Erin showed in her slide. And what's particular about Candida auris is that it colonizes and causes infection in the sickest of the sick, which are patients that you deal with every day. These are patients who are in and out of the hospital frequently, are ventilator dependent or have tracheostomies, are colonized with other MDROs, and frequently receive antibiotics and antifungals. And this is why places like skilled nursing facilities with ventilator units or VSNFs and long-term acute care hospitals or LTACs are most affected. A study in Illinois from 2016 to 2020, the prevalence of Candida auris was 7 to 24% in VSNFs and 12 to 25% in LTACs, while it was less than 1% in skilled nursing facilities. And we touched on colonization in earlier slides, and this point is really important for Candida auris because patients are often colonized indefinitely, and we do not have decolonization strategies. Candida auris can be commonly found in the skin, as shown in the figure on the right. Moist areas such as the armpit, the groin, and skin folds are the most commonly involved, in addition to the nares. And C. auris colonization is concerning because 5 to 10% of colonized patients develop bloodstream infections. Patients with bloodstream infections have a mortality rate of 45% in the first 30 days. However, it's important to note that because Candida auris infects patients who are already very sick, it's unclear what the actual mortality rate of Candida auris alone is. Now, one of the misconceptions that we often encounter is the concern that healthcare personnel can become easily colonized with Candida auris. So this has been studied in facilities with outbreaks that have shown minimal risk of colonization to healthcare personnel. A recent study of over 700 healthcare personnel providing care to patients with Candida auris showed that no healthcare personnel were actually colonized. But in addition to colonizing patients, Candida auris can colonize environmental surfaces. So this picture demonstrates where Candida auris was found after doing an environmental swabbing of 5 patient rooms that were positive for Candida auris. The bed rail or mattress was the most common site, followed by the windowsill. And Candida auris was also found on an infusion pump, a chair, and a countertop. And it's important because Candida auris can survive in the environment for a long time, and sometimes over a month. And Candida auris has also been identified on mobile blood pressure cuffs and portable pulse oximeters. And this is why dedicating medical equipment for Candida auris patients is recommended. Now on this slide is a perfect example of how Candida auris can spread rapidly within the facility. The picture shows the layout of a ventilator unit at a VSNF on March of 2017. Solid purple dots represent individuals with Candida auris, and at the bottom you will notice that there is a single positive patient in a private room. And in 10 months, the prevalence of Candida auris increased from 1.5% to 43%, with the facility now having 29 cases. And it's important to point out that it doesn't just affect roommates. All patients on the ward are at risk, even when some roommates did not acquire Candida auris. In addition, it's not just Candida auris that can spread rapidly. Individuals can be colonized with more than one novel MDRO. So in this picture, we show dots of other colors in addition to purple. These patients were colonized with Candida auris and other novel MDROs. So this is a really crucial point to remember, that novel MDROs tend to travel together. So now I'll talk briefly about the investigation led by Los Angeles County Department of Public Health with assistance from the CDC. And this investigation was in response to increased detection of Candida auris in long-term care facilities. As of November 6, 2020, there were 148 cases of Candida auris reported in Los Angeles County. And the objectives of the investigation were to assess infection prevention and control program, infrastructure, and practices in LTAC and VSNFs with recent or ongoing novel MDRO outbreaks or that were at risk of future outbreaks to identify factors that could be contributing to MDRO transmission. Second, to identify infection prevention and control changes in response to the COVID-19 pandemic that could contribute to reemergence of novel MDROs. And this included how facilities were implementing surge capacity strategies. And third, to use these findings to inform additional education and recommendations, which is why we're doing this webinar. So we performed infection control assessments of policies and procedures for infection preventionists and other facility leadership about IPC program staffing, MDRO detection, management, and prevention, facility staffing, hand hygiene, cleaning and disinfection, personal protective equipment supply and use, and we performed direct observations of the facility layout, performance of hand hygiene, cleaning and disinfection, and personal protective equipment use. We visited 12 facilities, 4 were LTACs, 8 were VSNFs. 5 facilities had Candida auris, and 2 had carbapenemase-producing organisms. Staffing, hand hygiene, cleaning and disinfectant, and personal protective equipment shortages were common. But we didn't find any significant differences in practices between facilities that had Candida auris or carbapenemase-producing organisms and those that did not. And facilities with Candida auris and carbapenemase-producing organisms were unlucky to receive a patient that was colonized with one of these organisms. And this could happen to any facility. So it's really important to strengthen infection prevention and control capacity in these long-term care settings. Now, we did identify several strengths in our IPC assessment. All facilities had active infection prevention control programs. Alcohol-based hand sanitizer was generally available, though not as much as would be ideal. And most facilities were using disinfectants that were effective against Candida auris. We did identify common infection prevention and control gaps that could help Candida auris spread. In the domain of hand hygiene, facilities reported preference of soap and water over alcohol-based hand sanitizer. There were missed hand hygiene opportunities when entering and exiting resident rooms. And alcohol-based hand sanitizer was available, but not outside and immediately inside resident rooms. In the domain of environmental cleaning and disinfection, we observed inadequate measurement and mixing when self-preparing bleach solutions. High-touch surfaces were often missed in cleaning and disinfection, and there was infrequent cleaning of mobile medical equipment. With regards to personal protective equipment use, we observed double gowning and double gloving at some facilities, the use of gowns with the back untied, reuse of disposable gowns, and using the same personal protective equipment for patients in the same room. We also found complicated and contradictory transmission-based precaution signage. And finally, some facilities were cohorting patients by organism and site of infection and infection status, which resulted in frequent and unnecessary patient movement. So now that I've highlighted these gaps, we'll shift gears and we'll talk about how we can address some of these areas for improvement. So we'll start with hand hygiene. So I think one of the other misconceptions that we frequently encountered was that hand hygiene with soap and water was superior at killing organisms on hands than alcohol-based hand sanitizer. Now, alcohol-based hand sanitizer is better than hand washing at killing bacteria and is also less damaging to the skin than soap and water. So alcohol-based hand sanitizer is really the preferred method of hand hygiene for most clinical situations. And there are 5 key moments for hand hygiene: before touching a patient, before clean and aseptic procedures, after body fluid exposure, and after touching a patient, and after touching a patient's surroundings. So think about a recent resident you interacted with and go through these 5 moments. Did you miss any of them? Which one do you think you miss the most frequently? So I think it's important to perform this exercise on an ongoing basis to ensure that you are performing hand hygiene during all 5 key moments. Now, another misconception is that healthcare personnel should perform hand washing with soap and water after approximately 3 resident contacts to reduce the transmission of organisms. This is not accurate. The indications for hand washing with soap and water are threefold: when hands are visibly soiled, after caring for a person with known or suspected infectious diarrhea, and after known or suspected exposure to spores, for example, in the Clostridium difficile outbreak. And 2 of the most frequently missed opportunities for hand hygiene are after removing your gloves and when moving from dirty to clean, such as when bathing a patient or treating a chronic wound. So I want you to remember that gloves are not a substitute for hand hygiene. And if you're caring for a wound or bathing a patient and touch a clean area on the patient or surface without performing hand hygiene, this could result in contamination with a novel MDRO. Now, there are several ways that you can improve performance of hand hygiene. One is to make it accessible in the places that matter the most, such as inside and outside resident rooms, common areas, staff workstations, and therapy rooms. In the setting of COVID-19, alcohol-based hand sanitizer supply may decrease, so make sure your facility has a plan for restocking supplies. And in the presence of shortages, one strategy to implement is distributing personal pocket-sized bottles of alcohol-based hand sanitizers to staff. Also, important to note that you should avoid topping off alcohol-based hand sanitizer or soap dispensers to avoid environmental contamination. Developing a training, auditing, and feedback system is crucial as well. To promote a culture of safety and teamwork when healthcare personnel and staff can remind each other to perform hand hygiene when witnessing missed opportunities. And there are several competency-based trainings, such as Caught Red-Handed, which is shown in this series of pictures, where staff wear gloves and use a colored dye to perform hand hygiene to see where they could have missed in spots. And of note, the most missed areas are thumbs, fingertips, and between the fingers. Infection preventionists or supervising staff should have an auditing program and have objective measurements of hand hygiene compliance. And there are some resources for these at the bottom of the slide.
We will now move on to cleaning and disinfection. One important point worth making is that cleaning and disinfection are separate and complementary processes. Cleaning is a removal of foreign material from objects, while disinfection involves the destruction of pathogenic and other types of organisms. Thorough cleaning is required before disinfection because any foreign material left on surfaces could interfere with the effectiveness of disinfectants. Now, another key concept is the contact or wet time, which is the amount of time that a disinfectant must remain on a surface to be effective. Now, this can vary by disinfectant, so it's important to make sure everyone who does cleaning and disinfection in your facility knows the contact time for different disinfectants. One strategy that works very well is to label disinfectants with contact times to ensure that they are used correctly. An example of this can be seen on the picture on the left. Also, high-touch surfaces are crucial areas for frequent cleaning and disinfection. These include doorknobs, bed rails, light switches, and surfaces in and around toilets in resident rooms. Other frequently touched areas in the resident's proximity include call buttons, remote controls, and tray tables, and these three were some of the most frequently missed surfaces during our assessment of facilities. Now, as I mentioned before, shared medical equipment can be contaminated and possibly transmit novel MDROs. It is important to make sure that these are cleaned after each patient use and that staff have a clear understanding of whose responsibility it is to clean the equipment. And it's important to include contractors in these discussions as well, as they may be using additional equipment that staff does not normally use. Now, another misconception is that all hospital-grade disinfectants effective against SARS-CoV-2 are also effective against Candida auris. Now, most quaternary ammonia compounds or quats are actually not effective against Candida auris. However, all disinfectants effective against Candida auris are also effective against SARS-CoV-2 and other novel MDROs. So we recommend you follow a tiered approach when selecting a product effective against Candida auris. Our first choice would be to select a product with EPA registered claims against Candida auris, which you can access using the first link on the right. If no products with EPA registered claims are available, then the CDC has performed its own testing and has an additional list of products which you can find on the websites listed by the second choice. If neither the first or second choice are available, you can use a product on EPA's List K, which is a list effective against Clostridioides difficile spores. Now, one of the changes that we saw in some facilities was that they were preparing their own bleach solutions because of shortage. This is an appropriate strategy, but you have to make sure it is performed correctly. Read the manufacturer label to understand how the product must be used and the necessary protective equipment needed. The link at the bottom of the slide provides information on recommended protective equipment. And remember to use germicidal and not generic household bleach. And I will make this point again. Surfaces must be cleaned before using disinfectants or they will not be effective. And this applies to bleach as well. The correct concentration of bleach to use is 5.25 to 6.15%. Dilute 1 part bleach with 9 parts of water and do not eyeball it. You need to use an accurate measuring instrument. Once you have combined it, you have to mix it. Do not assume that pouring the bleach and then the water results in proper mixing. If possible, prepare your bleach every day. If that is not possible, and make sure you store your bleach in an opaque container because sunlight can deactivate the bleach. You can store it for 30 days, but know that the concentration of bleach will drop by half by the end of those 30 days. So if you are planning to use a bleach solution for 30 days, consider preparing a 1 to 5 dilution so that at the end of those 30 days, you'll have a 1 to 10 dilution, which will still be effective against Candida auris. And as with hand hygiene, some helpful strategies to improve cleaning and disinfection are to assign clear cleaning responsibilities, develop audit and feedback programs, including the implementation of fluorescent markers, as the picture depicts on the right. Make sure disinfectants are available to all staff and provide training for staff. And I have added a reference to a CDC website with a toolkit detailing different ways of evaluating environmental cleaning and disinfection. And you should strongly consider using disinfectants effective against Candida auris, even if there have been no cases identified in your facility. We do not need a crystal ball to know that at some point you will come across a resident or patient with Candida auris. As we discussed earlier in the presentation, transmission and spread through a facility can be rapid and silent, especially in the absence of regular screening for colonization. By preemptively using disinfectants against Candida auris, you could slow and prevent the spread if your facility were to receive a colonized resident.
And I'll move now to transmission-based precautions. So gowns and gloves are recommended for residents colonized or infected with C. auris and other novel MDROs. And transmission-based precaution signs that are too complicated can lead to improper personal protective equipment use. So in this example, the sign is difficult to read. There's an unnecessary level of detail regarding the colors for different types of body sites and organisms, and does not clearly mention the need for dedicated medical equipment. In this second example, there are multiple signs, so it's difficult to know which one to follow. Also, some signs had conflicting instructions on how to perform appropriate donning and doffing. So these are some examples of simple and clear signage that is available on the CDC website. And if you decide to use your own, signs should clearly state the level of precautions, the required personal protective equipment, and any other special considerations, and should be placed immediately outside the patient's room so that people can easily access it. And when using personal protective equipment, proper donning and doffing are really important to minimize the risk of disease transmission. So it's important to train staff regularly and conduct audits on proper donning and doffing, as well as proper personal protective equipment use. And you can find instructional videos at the CDC website by following the link below. Now, one other misconception is that residents or patients that were previously colonized with Candida auris that test negative upon rescreening can have contact precautions removed. So there are several important points to be made about this. So first, colonization can last a long time, and we frequently see testing that is negative and positive from different body sites at different times. Second, that routine rescreening is not recommended. And third, so decisions to discontinue contact precautions should be made in consultation with the health department. And we'll move on now to patient placement and cohorting considerations. So for patients with Candida auris and other novel MDROs, private rooms are preferred. When private rooms are limited, you should prioritize these rooms for patients with uncontained excretions. But it's important to know that residents with Candida auris and other novel MDROs can be taken care of safely in non-private rooms. If you are cohorting, which is the practice of isolating multiple individuals with an organism together, keep it simple. During the pandemic, you should prioritize residents with COVID-19 for cohorting, followed by Candida auris. If you are cohorting Candida auris residents, remember to perform thorough environmental cleaning after any patient movement and frequent cleaning of high-touch surfaces. Beds should be at least 3 feet apart, and treat resident surrounding areas as separate. And if you are cohorting patients with other novel MDROs, it's not necessary to cohort by anatomic site or whether they are infected or colonized. And remember that even though you are cohorting for Candida auris, novel MDROs travel together, and it's possible that patients are colonized with multiple organisms. So once you're done caring for a resident, you should remove your PPE and perform hand hygiene before providing care to another resident, even if they are in the same room. So we released the last section, which is the strategies to optimize personal protective equipment supplies in the setting of COVID-19. The CDC first published strategies for optimizing the supplies of personal protective equipment in early February, right after the first few cases were reported in the United States, and CDC started becoming aware of impending personal protective equipment shortages. These strategies are organized using the framework of surge capacity and present options for conserving supplies according to 3 levels. Surge capacity refers to the ability to manage a sudden increase in patient volume that would severely challenge or exceed the present capacity of the facility. And CDC has also developed a tool, the burn rate calculator, to help facilities understand their personal protective equipment use and optimize supplies during the COVID-19 response. There's an online tutorial on how to use the burn rate calculator on the CDC website that I've included at the bottom of this slide. And as I mentioned, there are 3 levels of surge capacities. So conventional, shown in green, are strategies that already should be in place. Contingency, shown in yellow, are strategies that could be used during periods of anticipated shortages, and crisis, shown in red, which should be implemented when the current supplies cannot meet the facility's demand or anticipated utilization rate. Crisis capacity strategies are not commensurate with U.S. standards of care, and these strategies should be implemented sequentially, and crisis capacity strategies should only be used as a last resource. Now, I decided to highlight these strategies for gown use because this is where we observe many of the gaps. Conventional strategies include the use of isolation or other surgical gowns, as well as launderable gowns. Contingency strategies include the use of coverall, using gowns beyond the manufacturer designated shelf life, or using gowns and coveralls that are used in international settings. Crisis strategies include the extended use of isolation gowns, prioritizing gowns for high contact activities or activities where splashes and sprays are anticipated, and gown alternatives such as wearing disposable or reusable laboratory coats, reusable patient gowns, or disposable aprons. And it's important to note that once gown availability returns to normal, healthcare facilities should promptly resume the use of conventional practices. And I think it's important to make a distinction between extended use of gowns and reuse of gowns, as these are different strategies. So extended use is when a healthcare provider wears the same gown when interacting with more than one patient, housed in the same location, and known to be infected with the same infectious disease, in this case, COVID-19. However, this can be considered only if there are no additional co-infectious diagnoses that can be transmitted by contact, such as Candida auris. Now, reuse is when a healthcare provider wears the same gown for multiple patient encounters, but removes it after each encounter. When we observe this practice in facilities, healthcare providers would often hang their gown on a door hook outside or inside a patient's room and reuse it every time they cared for the patient in that room. Disposable gowns should not be reused, and reusable gowns should not be reused even for the same patient before laundering. And reuse may increase the risk of healthcare providers' self-contamination and is really not a recommended practice. And finally, I want to come back to communication. So ensure you have a system for communicating MDRO status at resident or patient admission, discharge, and transfer, and talk to your health department often to understand the epidemiological situation in your area. And good communication is a cornerstone of novel MDRO containment. So in summary, these are some of the take-home messages that Erin had presented earlier. But I think you can prevent Candida auris in your facilities, and remember the following 3 things if nothing else. So first, check that your disinfectants are effective against Candida auris. Because it persists in the environment for a long time, it requires thorough cleaning and disinfection, and don't forget to clean medical equipment. Second, make sure alcohol-based hand sanitizer is available in your facility and take steps to increase its access. And third, review surge capacity strategies. Make plans on how to implement these strategies in advance, and remember to implement them sequentially. So I'd like to thank the Los Angeles County Department of Public Health and the California Department of Public Health for organizing this. Also, all of the facilities and their staff who share their experience with us, and we'll be open for any questions. Just for a note, at the end of the slide, there are some resources as well for people who are interested. And I will stop sharing my screen.
We will now move on to the...
Yeah, go ahead, Lynette.
We will now move on to the
Go ahead.
We will now move on to the question and answer period. The panel will consist of our presenters and additional representatives from CDPH, the Los Angeles County Department of Health, and the Centers for Disease Control and Prevention. To ask questions during the Q&A portion, please use the Q&A feature, and your questions and comments will be read aloud and answered accordingly. To access the Q&A icon, use your mouse to click on your monitor screen, and on the bottom center of your screen, you will see several icons appear. Click on the circle with 3 dots. There you will see the Q&A option. The Q&A panel will open on the right side of your screen. We may not get to all questions today, but we'll save them to answer you directly after the presentation.
Now, Alfonso, are you able to see the questions in the Q&A? If you're speaking,
yes, I'm
okay.
able to see some of them. Would you like me to read them out loud for the panel?
Sure, perhaps just summarize them briefly, or I'm happy to help with that too, and then you can address them.
Sure. So I think the first question is from Derek Sheba, wondering, is the C. auris strain the same as the East Coast where C. auris is endemic? He mentions that he was informed from the Orange County outbreak was different and environmental contamination wasn't as much of an issue in spread. I think that's the first part of his question. And then the second part is, are we seeing C. auris being endemic in the specific facilities such as long-term care and acute care facilities? And I think that the difference between those.
So would you or anyone from CDC be able to address the differences between the C. auris strains? And I see Megan Lyman is on the call as well from the mycotics branch.
Yeah, this is Megan. I can answer the first one. So there are different strains in the U.S. There's 4 different clades, and it's predominantly one specific clade in California, and this is because it seems that there were multiple introductions into the U.S., and then there's been local transmission, so there's predominantly one clade. And those different clades do have different antifungal susceptibility patterns. And so the one in the Northeast is a little more resistant. Some in the Midwest are a little bit more susceptible. In California, which is part of the African clade, is kind of in the middle there. So, but we don't know a lot about how that actually, what that means about environmental contamination. So we do treat them similarly as far as infection control. There's really no differences.
Yeah, and so he was saying that it was different and environmental contamination wasn't as much of an issue in spread, but I think we would like to emphasize that, as Dr. Lyman stated, that environmental cleaning and disinfection is still absolutely critical, for C. auris anywhere, and that includes here with the strain that we have here in California. And then they're asking about C. auris endemic in a specific facility. And he's reading that C. auris is endemic in specific long-term care and acute care facilities. Maybe I'll comment, and then others are welcome as well, that, we do certainly see that there are facilities that, as Dr. Hernandez described, had the bad luck of having an introduction and then spread, and it can be, very difficult, especially once there's been, a lot of spread within a facility to completely eliminate, some ongoing presence of the organism. And of course, the patients or residents themselves remain colonized for long periods, and so would, potentially represent, a source of spread or transmission to others, as long as they remain in the facility. And so that may be what, perhaps you're getting at with regard to, having some facilities being, sort of becoming, having sort of endemic C. auris within them. But, that doesn't necessarily mean, or that doesn't mean that we can't, continue to do everything we can to keep a lid on it and to contain as much as possible, within that facility. And then, of course, the interfacility communication piece that Dr. Hernandez presented as well is also really, really critical, when there is that ongoing risk. And perhaps others have additional comments on that.
Yeah, this is Zach Rubin from Los Angeles County Department of Public Health. I can tell you from our experience, we have seen some facilities that have been able to, kind of eradicate the organism from their facility, and that's because they had a small number of cases, and then eventually those patients were able to leave the facility. I'm talking about long-term acute care and skilled nursing facilities. So that's really, I think, the key as well, is to try to build local capacity to to prevent transmission of the organism early on, because once it's kind of widespread in a facility, I agree with the question that it is very difficult to get rid of it. So the key is really to try to see if you can identify those cases proactively, or as soon as possible, and then put in place infection control measures to decrease the risk of transmission. Because you just once your facility is 20, 40, 50% colonized, it's very unlikely you'll really be able to get rid of it in any meaningful time period. So you want to get it when it's just one or two patients and stop it at that point.
Yeah, definitely agree. Early and aggressive. I'm seeing there's a question here about facilities saying that they're not able to use bleach or sporicidal disinfectants on certain pieces of sensitive equipment, and what are the recommendations for that? Any of our colleagues want to tackle that one? I guess I'll just start by commenting that always follow the manufacturer's instructions. That's sort of our default recommendation for any equipment that needs to be cleaned and disinfected between use. And so certainly look at your manufacturer's instructions and make sure that you're following them, and as was presented, ensure that is being done, regularly to. And I'm sorry, I think my phone might have cut out. Lynette, can you let me know? Can you hear me?
Yeah, we can hear you fine.
Yeah, we dropped you for a minute there, Erin. Sorry.
Oh, okay. No worries. No worries. Any other recommendation on the disinfectant?
Yeah, this is Amelia Keaton from CDC. So I think I've seen a couple of comments in the chat box that are helpful from, I'm guessing, some infection preventionists who have added that you can remove bleach residue using a soft cloth. I'll also just say that, bleach is a great disinfectant for sure, but there's other options out there that are non-bleach alternatives that are also effective against Candida auris. And we can certainly make sure to distribute the list for the EBS products that have tested efficacy against that. But I would also just echo what Dr. Epson said, and that it's really important to keep in mind the recommendations of the manufacturer. I also just wanted to point out a few other points about cleaning with bleach or sodium hypochlorite solutions. Yeah, I think it's become increasingly common during COVID as some of the other more commercially manufactured disinfectants were on shortage, that folks have made their own in-house bleach solutions, which I think is definitely an effective disinfectant. But there are a few things that Dr. Hernandez highlighted that I just wanted to reemphasize, which is that it's a light labile solution once you mix it, meaning that any light, whether it's sunlight or UV light or overhead lights, can degrade the solution. So it's really important to make sure that you mix solutions fresh every day, so every 24 hours, and that you store those in opaque containers where light can't degrade them. I think the other important point that he also made was that you have to make sure that you remove any other debris or residue or biologic material first, because while bleach is a disinfectant, it's not necessarily a cleaner. There's some products that are bleach-based that also have a detergent or a cleaner in them, but if you're just using, for example, Clorox germicidal bleach out of the bottle, you need to make sure that the surface is cleaned first. And I think it's also just important to note that the facilities that we visited in California had done, a really incredible job in really, really difficult circumstances. And even though we visited both facilities with Candida auris and those without, we didn't necessarily go in trying to find differences between the two, but we did identify practices, among all facilities that could potentially lead to the spread of MDROs. And so I think even if you are a facility that has not experienced Candida auris cases, just these basics of infection prevention and control will be very helpful in making sure that there isn't an introduction into your facility. Over.
Great, thank you. We have a few more questions and a few minutes left. There is somebody asking about chlorhexidine or CHG bathing, and a question about whether or not this can minimize or address Candida auris. Anyone want to take that one?
Yeah, this is Megan. I'll take that one. So there have been some testing of CHG in the lab, and it does, CHG does work to kill Candida auris, but that is, again, not in kind of the real world setting. And we have seen outbreaks even in facilities that are using CHG bathing. So I think there's still a lot for us to learn, but, a lot of it is how well CHG bathing is done, and there are a lot of body sites that can be colonized with Candida auris, not just the skin, like the nose. CHG bathing is not the solution, and I think we still have a lot of research to do about it, but and see if, like was mentioned in the question, can it even minimize transmission, but we don't have evidence right now that it can, and have seen transmission even when it's used. So I caution everyone to treat that as the solution. And I also see a question about biofilm. And again, that's something also being studied, but some evidence that might be related to why it's persistent on surfaces for so long.
Great, thank you. And let's see, there's one other question that maybe we can just touch on briefly. Once there is known Candida auris in a facility, is there a recommended surveillance plan to ensure containment? And, I think that there are a few pieces to that. One is laboratory surveillance of, Candida species that once Candida auris is in a facility, that a laboratory or a facility can, working with their microbiology laboratory, increase their, surveillance for, additional cases by performing species identification of Candida that is isolated in non-sterile body sites, such as, urine or respiratory cultures that, don't normally have species identified when Candida is found in those body sites. So that's one aspect of surveillance. But then the other is, we, for containment purposes, generally do serial or repeated point prevalence surveys where we collect composite axilla and groin swabs from all the residents in the facility that have been potentially exposed at regular intervals to check for colonization, and that helps us to implement control measures around those individuals who are found to be colonized. And gradually over time, the idea is that we have identified and implemented implemented transmission-based precautions and all the other measures that Dr. Hernandez described here to prevent any further ongoing transmission, and eventually we would contain or halt further transmission by identifying all those positives or colonized residents and implementing those measures. Does anyone else have any other comment on that response?
Nothing to add for me. I think you covered it.
Yeah, great.
Great.
Yeah.
Okay. And I think that we're, a couple minutes now past the hour. Okay, fine. One last question is, when can isolation precautions be lifted? And maybe I'll let another of our presenters address that. I think Dr. Hernandez kind of alluded to this.
I guess I can be the bearer of bad news. This is Zach Rubin from LA County Public Health, which is right now we're not recommending lifting isolation precautions because patients, are probably colonized for the long term. So until we get some, something to decolonize people with, I mean, chlorhexidine was mentioned, but doesn't seem to be the absolute answer for Candida auris. But until we get something like that, I think we're going to be keeping people in isolation precautions for the time being. There are some unusual situations where we have recommended decreasing that when patients go from a higher level of care to a lower level of care and have less risk of transmission, like in an assisted living facility or maybe a skilled nursing facility. But those are really unusual and far between. So at this point, we're not recommending that routinely.
Thank you. And I see one last comment here. Thanks, you guys. This was super informative, and I agree and will echo that. Thanks to all of you for the presentation, and especially for all of the work that you've done to assist with Candida auris containment in our state and in our local jurisdiction. So thank you all very much. Lynette, would you like to close us out?
Absolutely. Thank you, panelists, for today's informative presentation. This now concludes our webinar.